Director of the Center for Ethics and Human Values, one of the first sponsors of today's event. I'd like to welcome you to this event. This is part of the COMPAS program. COMPAS stands for Conversations on Morality, Politics, and Society. We describe it as a year-long university-wide conversation of some currently controversial topic that raises foundational moral questions and requires the expertise from lots of disciplines to address. This year's COMPAS topic is religion and public life, and today's event fits the description of the COMPAS program perfectly. We're going to be looking at the nature and justification of conscience laws, laws that are designed to protect healthcare professionals from engaging, to give them the permission not to engage in procedures or practices that go contrary to their sincerely held moral and religious convictions. And we have a terrific panel to address these questions to us. First, I want to mention a few words of gratitude. No event like this takes place without logistical support, and we have terrific logistical support in the person of Lavender and Kitchell Schweitzer and Krista Johnson, who is absent but deals with these things remotely, and our terrific associate director, Steve Brown, also sound technician, also video technician, also slash, etc. Today's event is co-sponsored with the Center for Bioethics, and we're grateful to them and to their director, Ryan Nash. Dr. Ryan Nash, so we're back for the sponsorship of today's event. I will introduce our moderator. Our moderator will introduce our panelists. I'm happy to introduce Dana Howard, who is fairly new to Ohio State, has a relationship with us over some years. Dana is an instructor in the Division of Bioethics, the Department of Biomedical Education, Anatomy, and she is a member of the Center for Ethics and Human Values Steering Committee. So Dana, if you will introduce our panelists, take it from there.
So thanks so much for inviting me to be a moderator. I'm so excited about the panel. I'm not going to talk too much about what this means because I'll let the panelists do the bulk of the talking. So let me just explain the structure of the event and then introduce the panelists, and we'll be set to go. So basically what we're going to be doing is first we're going to have Dr. Ronit Stahl talk about, and then, sorry. First, let me start again. First we're going to have Dr. Ronit Stahl, then we're going to have Dr. Abraham Nussbaum talk for 15 minutes each, and then afterwards I'm going to get the ball rolling with asking a few questions, and then open it up to discussion, because I think that's the most exciting parts of COMPAS is hearing what you, the audience, have to say, and the interaction between the panelists and the audience. So before letting Ronit Stahl come up here, I just wanted to introduce her. She's a fellow in the Department of Medical Ethics and Health Policy at the Pullman School of Medicine at the University of Pennsylvania. She's the author of Enlisting Faith, How the Military Chaplaincy Shaped Religion and State in Modern America, which has just recently been published by Harvard University Press. And she's the co-author with Ezekiel Manuel of Physicians, Not Conscripts, Conscientious Objection in Healthcare, which was recently published in the Journal of Medicine. Following that, Dr. Abraham Nussbaum is going to be speaking, and he is an associate professor in the Department of Psychiatry in the University of Colorado. He's also the chief education officer at the Denver Health. And he's the author of The Finest Traditions of My Calling, One Physician's Search for the Renewal of Medicine, and that's a memoir about practicing medicine in an era of healthcare reform, which was recently published by Yale University Press. So each panelist is going to have 15 minutes to speak. I'm going to ask a few questions, and then we're going to open it up. Thanks so much for coming.
Thank you for having me here today. Thank you to the Center for Ethics and Human Values, the Center for Bioethics, Don, Ryan, Dana, everyone who's made it possible for me to be here today. I'm going to speak briefly. As she just said, I'm going to offer one perspective on conscience laws, and then I'm looking forward to a robust and engaging discussion. So, as Don mentioned, this is quite a moment for conscience laws and conscience and religious freedom in the United States. Just about a little over a month ago, I got the new Division of Conscience and Religious Freedom in the Office of Civil Rights in the Department of Health and Human Services. And so part of what I want to do today is what I'm calling troubling conscience laws, to both consider how they might be troubling, but also to trouble the idea and concept of them. And when this division was announced, there was a number of officials who stood up to speak in support of it, and a number of practitioners as well. One of those practitioners was Sarah Helvege, who had applied for a position as a certified nurse midwife at Tampa Family Health Centers. That's a network of nonprofit clinics that, according to its website, provides high-quality, affordable, and patient-centered care. It's also one of Florida's Title X family planning clinics, which means it provides comprehensive family planning services, including FDA-approved contraception, emergency contraception, sexually transmitted infection testing, and pregnancy tests to low-income patients. During the hiring process, Helvege disclosed that, quote, as a Christian, she could not prescribe contraception because it was, she claimed, quote, an abortion-inducing medication. That is, she believes that life begins at conception, and she believes that contraception therefore threatens the lives of embryos. After the clinic declined to hire her, on the grounds that she would be unwilling to perform a central part of the job, which was discussing, counseling, and prescribing contraception, she sued. Her lawyers, through the Alliance for Defending Freedom, argued that federal and state conscience laws protected her right to be hired. So last month, when she helped launch the ceremony to announce this division, she was there to represent the kind of provider that the Office of Civil Rights now seeks to protect. She offered her story to testify to the importance of protecting conscience and religious freedom in healthcare. No one, she asserted, should face discrimination because of beliefs, conscience, or faith. No one, she implied, who wanted to be a healthcare provider. She didn't speak, of course, of the patients who might seek her care. So is she correct? Well, as for the legal case, there were technicalities that prevented her lawsuit from moving forward. But the question remains, should Helvege or someone like her be protected? And legal questions aside, should professional medical ethics accept this exercise of conscience and religious freedom as an acceptable and normative professional practice? So there are these conscience laws, a collection of about 25 federal statutes and many more state statutes that have been created since 1973. And in various ways, they shield healthcare providers from needing to perform or provide healthcare that violates their religious beliefs or moral convictions. There are also professional ethics, the codes of conduct and statements of ethos that guide the profession as a collective. So today I'm going to argue that these conscience laws and professional ethics collide and conflict, creating a tension that I think the profession should not legitimate. In other words, as I said before, I'm using troubling in two ways. The ways in which troubling in the sense of finding these laws troubling, but also to trouble the laws and the concepts behind them, to complicate what they mean and how they work. So as Dana mentioned, last year I published an article arguing the point that I'm going to make shortly, that to invoke conscientious objection is to reject the fundamental obligation of healthcare, the primary duty to ensure patients' continued well-being. In this sense, conscience laws place a professional's personal religious and moral beliefs above professional standards. And it is a conflict of interest, albeit a non-financial one. So we often, in medical ethics, talk a lot about conflicts of interest, but primarily related to finances. And this has created an imbalance in which the religious freedom, or rhetoric of religious freedom, has become synonymous with justifying a very particular set of religious worldviews at the expense of patients' access to care. It also erases professional obligations from the conversation. Because when you invoke these conscience laws, that's the end of the story. You have your rights. And yet, professional associations set many norms and expectations for professional behavior. And in this regard, I think they should authoritatively articulate the professional ethical standards to which all licensed healthcare professionals must adhere. Now, my personal work on conscientious objection in medicine began when, several years ago, I started hearing about a public discourse around conscientious objection or religious refusal in medicine that invoked the military. And as Dana noted, my first book looked at the military and the military chaplaincy. So as someone who spent years researching and writing about religion in the military, I found this discourse fascinating, but also a bit unsettling. I recognized the intuitive appeal of connecting the two forms of conscientious objection. It is, of course, the same language. And also, several of the legislators who supported the first federal healthcare conscience law clause, which was the Church Amendment, named for Frank Church, not the church. It's a little bit of an annoying name you always have to clarify. But some of those legislators indeed suggested that these rights of conscience were the exact same thing. But the more I thought about it, the more I found that the assumptions about parallels didn't stand up to scrutiny. Despite the assumed congruence between conscientious objection to war and conscientious objection in medicine, they are not the same. And specifically, what my co-author and I argue is that healthcare professionals are not conscripts, and in a freely chosen profession, conscientious objection cannot override patient care. So let me explain what I mean by this, and what I mean by the incongruity that I'm arguing about. And I should note there's a long history of conscientious objection to war, especially by pacifists and peace churches. And I'm going to focus on the military starting in 1917, because that's when we get the first nationwide draft, and the Selective Service Act of 1917, which sets the parameters for what we call the selective service system and the ways in which the rules that regulate conscientious objection to war, which have changed over the 20th century. A few key changes are that they moved from, in World War I, only applying to pacifists who are members of peace churches, to by World War II, applying to individual objectors, and by Vietnam, no longer requiring a belief in God, but requiring a moral conviction against war. So how does this, and as you see this draft registration poster and a draft registration card, which notes that someone has to show up to the board and must show up lest they face penalties, how does this compare to the questions of conscientious objection in medicine, where instead of a draft board or a selective service system, we have professional codes of ethics? And in this case, one of the key pieces of the American Medical Association's Code of Ethics is that physicians' ethical responsibility is to place the patient's welfare above the physician's own self-interest. And of course, we may define these terms different ways, but I think it's important to set this out as a key plank of the Code of Ethics. So what are some of the ways I'm going to argue that these are different? First, I think the target of the objection is different. When someone objects to war, they're objecting to a state-mandated form of conscription. But when someone objects in medicine, they're objecting to professional practices and to patients. That's who bears the brunt of the objection. And I just want to clarify that in the context of healthcare, I am talking about patient-requested, medically accepted interventions. So I'm not talking about something that the patient does not seek, and I'm not talking about something outside of the realm of professional medicine. So homeopathy, or say someone who's like, I really want leeches. I'm not talking about that. Just I think it's important to note. This is, for example, a woman seeking a tubal ligation, or voluntarily seeking a tubal ligation or a sterilization to avoid future pregnancy, which is a medically accepted form of permanent contraception, again, if it is patient requested. And so again, if someone objects to that, they're objecting to something that's a professional standard that a patient seeks, not to something the state is requiring them to do. Second, the context is different. In the case of conscientious objection to war, someone is objecting to conscription, to being in an unchosen combatant role. That's what happens when you get into the military via the draft. You're put into a combatant role. In healthcare, however, it's occurring within a freely chosen profession. Someone elects to become part of the medical profession, to go through the requisite training, to acquire the appropriate credentials. And people make all sorts of choices based on all sorts of criteria. What kind of medicine interests them, what role they want. Do they want to be a doctor, a nurse, an EMT, a pharmacist? What patient population do they want to work with? What hours or lifestyle or income do they seek? And people can weigh whatever factors they value in whatever proportion they deem important. But the important feature here is they have a choice. You don't have to go into medicine. Third, when conscientious objectors to war filed their paperwork with a local draft board, they had to object to all war. In fact, in 1971, the Supreme Court ruled that in order to qualify for CO status, one specifically had to oppose all wars. Selective objection, that is objection to specific wars, and this was common during the Vietnam War era, an objection to Vietnam, but not, for example, World War II, would, in the words of Justice Thurgood Marshall, endorse the danger of erratic decision-making, prefer the more articulate, better educated, or better counseled objector, and be partial to the more familiar or conventionally religious type of objection. In healthcare, by contrast, selective objection is common. Take Sarah Helvege, for example, the woman with whom I started. She said she would not prescribe birth control pills, but would assist in a tubal ligation. That is a distinction that mattered to her, and I don't doubt that. But it's hard for a patient to know how someone is going to have these very different views on what are all contraception. Or take a fertility clinic that aids an infertile heterosexual couple, but objects to serving a lesbian couple. These are selective decisions that may well comport with religious doctrine, but nevertheless fall into the dangers that Justice Marshall identified about selective objection. Fourth, there was nothing automatic about being a conscientious objector to war. During World War II, the iconic Good War, to which there were fewer objections, 72,000 men applied for CO status. They had to write narrative statements about the nature and sources of their objection. And they had to demonstrate their sincerity and commitment to local draft boards who evaluated them, who questioned their convictions. Only about half of the requests were granted. In contrast, there is no scrutiny or even a system for assessing conscientious objection in healthcare. We hear about cases when people lodge legal complaints because they think their legal rights, that is, the rights of the provider, were abrogated. The rest of the time, however, when healthcare professionals simply enact their rights by not providing a treatment or writing a prescription or giving a referral or even giving accurate information, there's no record or trace of who objected or why. There's no way for a patient on the outside to identify who might object to what treatment. Finally, to conscientiously object to war did not mean that men simply went back to their regular lives. Instead, they were required to perform alternative service, either non-combatant military service, such as serving in the medical corps, or contributing to civilian public service work. In World War II, the selective service oversaw the CPS system, approving or rejecting what counted as public service. Most frequently, men worked in forestry camps, akin to the civilian conservation corps work, and in approximately 3,000 cases served in mental hospitals. And I think you might hear a little bit more about this in a bit. CPS was a compromise of sorts. Absolute pacifists like Quakers wanted nothing to do with the selective service system, whereas Mennonites accepted an obligation to serve the nation. But all of them, Quaker or Mennonite, had to work within this system, because those who refused faced prison time. And none of those who served in CPS camps were paid. The state, therefore, disciplined these objectors, allowing the objection or requiring compensation for the burdens presented by their refusal to bear arms. In contrast, conscience laws in healthcare immunize healthcare providers from penalties and costs. Or according to the current administration, they have failed if they do not shield healthcare providers from these penalties. From this perspective, healthcare professionals who engage in religious refusal or conscientious objection should be able to continue to do the work they choose, see the patients they want, provide the specific care they want, and earn their professional salaries without any penalty or even malpractice suits. The burden is borne by patients who can't access services and by other professionals who take the load that objectors refuse. Many state-level conscience laws even shield healthcare providers from malpractice suits or censure from licensing boards, even for refusing to provide accurate information. So in other, less politically fraught areas of medicine, they could face penalties for the failure to act, refer, or provide information. But in realms protected by conscience laws, typically around reproductive health care, end-of-life care, and now we're seeing LGBT health care, there's nothing that stops someone from acting according to their conscience and stopping the patient from accessing the care they seek. So again, I'm speaking of 5 different ways in which they're different in terms of the target of the objection, the context, the type, the assessment, and the consequences. And this is why I think there's actually very little in common despite the shared rhetoric, such that when this is allowed, it's in an imposition of personal, religious, and moral beliefs on patients, which leaves no space for patients to articulate and act on their religious and moral views, and can leave patients who have the least amount of power in a system that requires extensive credentialing with little recourse. This is not a space of equal standing, but a space of power relationships that matter, because there is an asymmetry of both knowledge and power in the provider-patient relationship. So I want to be clear about what this means. When I resist conscientious objection in these conscience laws, I'm not saying that we need to force healthcare providers to provide care that violates their conscience. I am saying that it is critical for people who choose to enter the healthcare profession to assess their values in advance and to seek alignment between their particular specialty and their values. So in the case of Sarah Helvig, she is of course welcome to her beliefs and she can be a nurse. But if her personal religious beliefs do not allow her to prescribe contraception, then she, as someone who has voluntarily entered the profession, needs to seek a job that aligns with those beliefs. A Title X family planning clinic is probably not that space. And so all of this raises the question, when we're talking about conscience and religious freedom, whose religious freedom, whose conscience counts, whose values matter? And I argue that since healthcare providers voluntarily choose their roles, and that choice obligates them to adhere to professional standards of care. And of course, values can compete, conflict, and collide, but it is incumbent on those who are choosing their profession to choose wisely. Thank you.
I also want to begin with gratitude, and I want to thank you for having me out here in Columbus, Ohio. I've never been here before. It's terrific to be here. I got to speak about marijuana this morning, and now we get to talk about conscientious objection. I'm here in part because I got to enjoy this terrific book that Ronit wrote. I really recommend it to people. It's a good read, and I want to thank everybody for having me out here. Today, like I said, I enjoyed Ronit's book, which is about how the American military shaped religious practice through its chaplaincy. Today we're going to discuss conscience in healthcare through her New England Journal of Medicine essay that she authored last year, in which she draws this analogy between healthcare professionals and military conscripts. Professor Stahl argues that since healthcare professionals, unlike military conscripts, freely choose their profession, they're obligated, she says, to provide, perform, and refer patients for interventions according to the standards of the profession. To explain why, she identifies 6 differences between military conscripts and healthcare professionals. The first is that healthcare professionals object to professional practices, not state-mandated conscriptions. The second, as she said just a minute ago, is that it occurs within a freely chosen profession. The third is that it allows selective objection to professionally accepted intervention. The fourth is that it accepts objection without external scrutiny. The fifth is that it shields the objector from all of the costs. And finally, she writes that healthcare conscience clauses are one-sided, protecting only those who refuse to treat patients. Professor Stahl observed that when acting as a health professional, practitioner is obligated to follow the morality specific to his or her role, namely that they have a fiduciary responsibility to subordinate their own interests to those of their patients. And she asserts that religious convictions are secondary to this fiduciary responsibility and offers 3 telling examples. that a Jehovah's Witness surgeon could not refuse to allow blood transfusions, a Jewish pharmacist could not withhold kosher pills, and that a Mormon nurse cannot refuse to treat alcoholics. Okay? She says anything else violates the commitments to fiduciary responsibility. She goes on to assert that physicians must perform medically accepted procedures and refer for professionally contested interventions which they will not perform themselves. Practitioners, unwilling to do so, she says, must either select a clinical practice which does not conflict with their personal morality, or they must leave the profession. I read this article soon after they came out, when many of my friends, families, and patients were asking what it means to resist the prevailing forces of the world. I work every day at an academic safety net hospital in downtown Denver, and I serve as a physician on our adult inpatient ward. Most of my patients are members of minority groups, only half of them speak English, and 85% of them have public insurance. Reading this essay and thinking about how to serve my patients, I thought of my own professional society. I published 3 textbooks of my professional society, and I am a card-carrying distinguished fellow of the American Psychiatric Association. But as I read Ronit's essay, I was as it happened, on my way to the American Psychiatric Association's annual meeting, where resistors have historically expanded the imagination of my professional society. After all, it took a group of resistors pictured here at a previous APA annual meeting to convince my professional society that homosexuality is not a mental illness. You see here was previously the diagnosis of sexual deviation. I believe that we need people outside of professional society to see what we fail to see. When you become a member of a professional society, you see the limits of that kind of community, which are often more focused on preserving the authority of the members than serving patients. So I'd like to tell you a little story about what it's like to become a health professional. When I finished medical school, I received 4 gifts from the hospital. You're going to finish med school soon, right? You're already wearing one of the gifts. The first gift I received was the white coat, which was the mantle of my authority as a physician. The second was a pager, which made me available to my patients at all times. The third was a set of keys to the locked units of the hospital. And the fourth was assault training. I was taught in the orientation of psychiatric residency how to prevent assaults, but if necessary, to perform takedowns and coercive care. This was never something that was told to me in medical school. I was never told that as part of my training, I would be expected to take down patients and participate in coercive violence. And yet, after I had entered into the binding match, which you're in, some of you who are medical students, after I had signed up for the profession, then I was told what it would hold. So, on the second night of my internship, an exhausted colleague handed me the call pager for the first time. She told me not to call her or the attending physician while I was on call for the next 3 hours. As she drove away, I realized I was the last physician standing, the only on-call physician for a large state mental hospital named after its founder, the terrific 19th century social reformer Dorothea Dix. By the time I arrived, most of the acreage of Dorothea Dix had been sold to developers, and most of the patients had been turned onto the streets. But in its diminished state, Dix still felt like a failed nation state. Overgrown with stands of long-leaf pines, its remaining buildings falling back into the earth. But there were still 26 separate buildings we covered while on call. One whole building housed adolescent boys who yelled all night. Another, old men who slept all day. Some buildings sheltered women who plucked unseen bugs from the air. Others, girls who cut their legs open in red, ragged strips. All told, the hospital accommodated 600 patients over hundreds of acres, all behind locked doors. How do you manage all those people in the middle of the night? When you're told that you're alone and not told to call anyone? The answer is that you learn very quickly to have efficient encounters which are often coercive. You find yourself saying to a patient, even though you swore you never would, take your meds or else, right? And you're formed in coercion. And in the spare moments of being on call, I found myself here. There's a chapel at Dix. I never visited the chapel, but I haunted the library. I have a confession to make to you, which is that I'm a nerd. That's how you come to write books. I think it might be safe to say this is a nerd panel, making an assumption here, but I found myself in the library. And in the library, I started looking for some other solution than what my profession was offering me. And while there, one night, I found this book. Had a cheesy cover from the 70s. I had never heard of this before. Something called The Mennonite Mental Health. It was never discussed in my med school. I never heard of it. And in the pages of this, they talked about how they pioneered the non-coercive care of persons with mental illness. Reading the book, I had to learn what a Mennonite was. I'm not a Mennonite. I've never been a Mennonite. I've never been to, well, since writing a paper about them, I've been to some Mennonite events, but I'm not a Mennonite. And I knew on some level that Mennonites were pacifists, but I didn't really know what that meant. Mennonites would say that they practice a version of pacifism they call non-resistance, which is that they meet violence with non-violence. And they make a distinction between the Quakers, who they would say demand justice, and themselves who do justice. This is an intra-Mennonite Quaker fight, but that's their account. They would say that the Quakers go and organize meetings and form committees, and the Mennonites just do justice. And they would say that the most important thing for them, what it means to be a member of their community, is to practice discipleship. And that discipleship requires non-resistance. That if you do not perform non-resistance, you have to leave the community. Mennonites, like the doves on their cover, this cheesy, see that cheesy dove? Right? They got one of those, right? They migrated. And historically, they have migrated when states have compelled military service. So that's where most Mennonites are. You can see there used to be a lot of Mennonites in Russia. There are no more. Right after the Tsar was assassinated, they left. Right? And they wound up many of the United States, but also parts of Africa, South America, and the Philippines. So I read this book when I was on call one night, and they talked about this. Does anybody know where this is? What happened here? You guys know? Ronit?
No, you got it. That's
Okay.
your story.
Okay, this is not my story, right?
Well, I mean, it's your.
This is not my story. This is a picture of Fort Leavenworth, the U.S. federal prison in Leavenworth, Kansas. During World War I, Mennonites and other members of the peace churches who refused military service were profoundly excluded from American society. They were ridiculed or even imprisoned for their pacifism. While their sentences were later reduced or commuted, 17 American conscientious objectors were sentenced to death by the United States, 142 to life imprisonment, 85 to prison terms of between 25 to 50 years, and 301 to shorter terms. 2 of them died while in custody here at Leavenworth. At the war's end, the peace churches negotiated with the federal government for alternatives to military service. The Quakers wanted an exemption from compulsory service. But the Mennonites said, we want alternative service. My first job, anybody who ever gone to grad school has a series of cruddy, bad jobs. My first job was working for a professor and reading microfiche of the Christian Century. Somebody know what the Christian Century is? It's a liberal Protestant journal, and we were looking at it for various reasons on microfiche. It was named the Christian Century. They founded it in the 1890s because they believed that the coming century would be the most peaceful century of all time. They believed that there was no way that there would be war or violence in the 20th century. And after World War I occurred, they wrote, and it was heartbreaking to read, because they wrote, that was such an awful war, we will never ever do it again, right? And you knew, of course, that horrible things were coming, right? The Holocaust was coming, right? Stahl was coming, he was gathering steam. The Mennonites knew from the very beginning. They started in 1919, knowing that another war was coming. They were not deluded to know that more conflicts were coming. So they began negotiating, right? And the Mennonite Compromise of compulsory but non-violent service was adopted as the blueprint for the civilian public service. Before Pearl Harbor, the federal government put Mennonites in civilian public service camps here, doing trail work, often on old CCC camps. If you go and read official Mennonite histories written right after the war era, they'll observe that they were willing to undergo compulsory service. They said, look, as long as it did not violate their consciences to perform work of national importance when commanded to do so, but they would not engage in the work. But the Mennonites Mennonites wanted to do direct service. And when they were here, part of why they were here in these remote places is the federal government didn't want them to be visible. They wanted them to be hidden from society. So they put them in small camps, off in the woods. The Mennonites said, we're fine doing this, we're willing to do this, but we want to do direct service to other people. At the same time, state psychiatric hospitals, all of the men, and they were mostly men, are drafted. So state psychiatric hospitals are left without attendants. In the war period, before we had any effective psychiatric treatments, at these psychiatric hospitals, all of a sudden, all of the techs were drafted. And in some of these hospitals, they were left with one tech for every 1,000 people, right, without any form of medicine. Now let's take a step back and talk about the forces that the federal government can exert on a young man. In World War II, approximately 10 million men were drafted. 37,000 were conscientious objectors. If you took non-combatant roles, largely as a medic, you received access to military benefits, including pay, the GI Bill. If you insisted that you did not enter the Civilian Public Service Corps, Civilian Public Service, you received no reimbursement, no GI Bill. And some of them served from 1939 to 1947, well after World War II's violence. About 12,000 served in psychiatric in the CPS. And when the Mennonites and other members of the CPS began writing asking for direct service that they could perform, at the same time the administrators of state psychiatric hospitals were asking for help. And approximately 1,500 Mennonites and 3,000 total CPS members went and worked in state psychiatric facilities. They were joined by approximately 400 of their wives who volunteered just to work there. So this is not many people. It's about 1,900 people total, Mennonites serving in mental hospitals. But in a minority religion like the Mennonites, 1,900 people was approximately 1 out of every 100 Mennonites in the United States. They spent the 1940s in direct care of persons with mental illness without pay. In doing so, they pioneered non-coercive care before we had any effective psychopharm. When they showed up on the floor, they were handed blackjacks. Does people know what a blackjack is? And they were told that if patients got out of line, they should strike them. The Mennonites refused to do so. And the other texts would say to them, how is it possible that you can care for these crazy people without using coercive force? And the Mennonites said, we'll do this. We'll sit with them, we'll care with them. And the Mennonites become extraordinarily effective, so that state psychiatric hospitals offer to turn their hospitals over to the Mennonites. Literally, I'm not making this up, right? In Maryland, they do this. They ask if there's more Mennonites available to work here because they can do what other people cannot. The Mennonites start to think, maybe we should run a state psychiatric hospital. And they engage Carl Menninger of the Menninger Foundation. They engage Robert Felix, who becomes the first director of the NIMH. And they decide ultimately that there's too many problems with working in the state system. So after the war, they built 8 mental facilities, again before we had any psychopharm treatment, across North America, which embodied their model of person-centered and non-coercive care. 7 of these 8 facilities still exist. And they saw, importantly, all comers, anybody who needed the care that they could provide. They have subsequently published books like this, which describe how to surround a person with mental illness in a community. In short, while being trained how to quickly and efficiently move patients safely through a psychiatric hospital, I was taught coercive care. That's what my profession taught. But when I read the Mennonites, I found that through their non-resistant resistance, Mennonites were practicing everything my profession was not teaching me. The Mennonites showed me that something more than institutional care or technocratic medicine was possible. This young woman and this kind of work is what conscientious objection looks like to me, a member of a profession. And when you think of conscientious objection in terms of resistance that leads to non-resistance, the argument that Professor Stahl argued in the New England Journal of Medicine looks very different. The first difference she enumerated is how the first difference that I think that you see once you think about the Mennonites is that conscientious objection is always an objection to performing practices, and only sometimes to conscription. And you also think about how professional practices are often in error. When you think about her second difference, you see it misses how an initial choice, my decision to become a psychiatrist, is not an assent to every act a profession requires of its practitioners, right? An initial choice is not an assent to every act that a profession ultimately decides. As a resident, I quickly realized that different people within the profession have very different authority to alter practices. At my best, I also realized that physician responsibilities arise not because we voluntarily assume them, but because of the vulnerability of the people we meet as patients. Resisting these systems, as the Mennonites did, taught me that conscientious objection affects everyone, including personal identity and community membership. And that professionals have identities before they become health professionals. And these identities are altered, but ongoing, while wearing the white coats of our professions. For the Mennonites, as for most of us, there is external scrutiny beyond our professions. Within the profession, there are significant repercussions and costs for not following its dictates. Outside the profession, there are extra-professional repercussions and costs to resistance. Finally, I believe that the argument neglects the ways that a communally developed conscience is why a person becomes a health practitioner. A community-developed conscience is why the Mennonites volunteered to work in the state psychiatric facilities. It's also why I was there. Now, since I am a psychiatrist, I want to observe something about the structure of the argument that Professor Stahl has laid out. In her argument, a practitioner's choices are loyalty to the profession or exit. The rhetorical strategy is disqualifying people from dialogue. The trouble with this is that you can suppress conflict and have it erupt elsewhere, or you can welcome the conflict which accompanies living in a pluralistic society, and I would say with being human. And I also believe there's another option that she did not enumerate, which is pluralism and dialogue. Just as a brief sketch, I think it's all we have time for, here are three alternatives for pluralism and dialogue. The first is Jonathan Haidt's book, The Righteous Mind, which argues that we misunderstand how we reach decisions. He argues that our emotions guide our decisions and we explain them after. In today's divided world, Haidt argues for empathy and dialogue. In her book, Conflicts of Conscience in Healthcare, Holly Fernandez Lynch shows how health systems can design options to honor the commitments of patients and practitioners alike. And finally, in his book, Confident Pluralism, John Anuzu encourages tolerance and humility while building relationships across our differences, instead of excluding people from a conversation or a practice. These books, like the examples of the brave men and women who resisted my profession's declaration of sexual differences and mental illness, and the Mennonites who resisted my profession's acceptance of coercive violence as treatment, taught me that how resistance to professional societies can, if we commit to dialogue and alternative service, expand our imagination of what is possible in the care of the people we are privileged to meet as patients. Thank you.
All right, that was really terrific. Thank you. So maybe before I ask any questions, why don't I open it up and invite Dr. Stahl to respond, and then also invite Dr. Nussbaum to respond in turn.
Thank you. Thank you for, is this on? I'm not even sure. But can you hear me? Okay. Thank you for a really thought-provoking presentation. Sorry, this is stretching me. Thing I keep coming back to is I really appreciate the example you give of resisting with non-resistance and the ways in which the Mennonites, through their service, ended up changing for the better mental health care. But it does seem to me there are two other things going on that are maybe pushed to the side. One is that they are operating within a system of service, right? This is not them just deciding on their own to create an alternative, to just lodge their objection and move on. There's an infrastructure around them that they are working within. And that's the sort of foundation for the ability for them to enact the change they enact. And it's not clear to me that in contemporary conflicts that there's either that mentality or that foundation, or frankly, a system at all. And that gets to my second, I guess, question for you, which is, where again do patients fit? The patients who are requesting care, who aren't able to access it. I've spent time this fall in a family planning clinic in which there were patients who had been tossed around, turfed in the language of healthcare, from multiple clinics and hospitals, getting incredibly frustrated by their inability to access care. And where do they fit in this model? How do we ensure that patients can still access care?
I think those are two great questions. The first I would say is, did the Mennonites operate in a system of service? Yes, but it was their system of service. They created the CPS. But the they did. They negotiated that with the federal government. They knew that another war was coming. But the pivot to psychiatric hospitals was made up on the fly. As far as I can tell, they had no plan that was going to happen. That was just a need that they came to fill it. The system of service they had was what was trained by the Mennonites. When you go back and read what they say again and again, is the fundamental treatment we provided was the care of a Mennonite family. That was their model for care. Is they said, look, we think that what these people need is, until we have effective treatments, we're going to treat them like they're a member of our family. So the Mennonites in Goshen, Indiana, open up a foster care system where they say, if your family is in the psychiatric hospital here, it's really expensive to come and visit them. So we'll open up our homes to you, and you can come and eat with us. Because they believed that was the treatment. So the system that they had isn't from a profession. It was from their alternative way of life. The second question is, where do patients fit? With all due respect, this question is much broader than you've asked it, right? So I am in a medical profession where over half of all members of my profession do not take any form of insurance at all, let alone accept public insurance. So when you say that a professional society is going to preserve what happens for patients, my professional society, and again, I'm a distinguished fellow, I am on the editorial board of the American Psychiatric Association, and they drive me insane because they can't even get us to say, we're going to commit to see poor people with mental illness. Just that. So in your argument, you say that you collapse two differences. One is to refuse a patient, and another is to refuse to see a patient, and another is to refuse to provide a professionally sanctioned practice. Those are two very different things. I will fire somebody in my hospital if they refuse to see any patient. It's a different thing to say I'm going to refuse to participate in certain practices. That's totally different. So in your article, I said that there was a telling example about a Mormon nurse. So we debated your paper at the University of Utah. And I'm not Mormon. I've never been Mormon, but I'm from Colorado. There's a lot of Mormons, but I figured Utah was the place to ask. So in your article, you say you use three examples. And one of them is a Mormon nurse refusing to treat an alcoholic. So I just asked them, have you ever heard this? Is this ever an issue? They're like, no. They didn't know of an example. And that's a very important distinction. If somebody's refusing to see patients, that's what I wish you would get to. Because every day, all day long, we have health systems that are set up to discriminate against the poor and the vulnerable, right? That is the daily quotidian experience of the poor and the vulnerable in the United States. And professions are horrible at that. So where do patients fit in? Honestly, professions are the wrong place to make an argument for their profession. Just
Right.
They're guilds.
So just about those examples, we picked them because those are examples that would fit the terrain of either federal or state conscience laws, but aren't actually protected actions, that no one is saying this is acceptable. And I think that's part of the challenge with there's the conscience laws on the books, and there's the idea of conscience and conscientious objection. And the way in which both federal and state laws are structured, and state laws vary, there's variation between states to be sure, is that is plausible in any number of states. And that the locus of objection is in certain realms of healthcare. I've talked to many residents, I'm sure you know many doctors too, particularly in critical care, who feel incredibly frustrated that they feel forced to provide aggressive end-of-life care treatment,
Sure.
right? They feel like they're harming patients. And technically, in most states, they could refuse, right? The laws on the books in many states would allow them to refuse to provide that care. But everyone I've talked to has said, yeah, I've never felt that was actually possible, that within the world in which I exist, that I could do that. And some of them are saying, well, now if we're really gonna, like they said, with the new administration's filing of complaints, that's what they're going to start filing complaints about, which is not the conception that we have publicly about what these laws do.
So you want to have it both ways, right? You want to say that people are embedded in such a system that they can't imagine other possibilities. And you want to say that there's no cost to resisting the system. There are profound costs to swimming upstream against these systems, right? And I think it's important that if you're going to use examples, you use the examples that you really think are what's going on. And to me, the single largest exemption of people who are refused every day is that the poor are excluded. So, I mean, so I practice in
But that's not by law. That's not a permitted mode of conscience, of conscientious objection.
So one trouble with your argument is that you base this on professional societies' ability to do that. Professional societies allow that all the time, right?
But that is not permitted legally because of conscience laws.
Let me interrupt.
Yeah.
Because I think a lot of people are going to be asking a lot of questions, and so maybe one place to potentially continue this exact conversation is John Rawls makes this distinction between conscientious objection and civil disobedience, right? And so civil disobedience is this sort of idea that it's public, it's nonviolent, and the end point isn't just to sort of withdraw or refuse something, but to actually change the system or change the governing rules. And I wonder if part of the argument here is like in defense of civil disobedience when it comes to some of these professional laws and professional regulations versus conscientious objection, which does seem to have this sort of retreat, this personal, I'm not comfortable with some sort of legal, like some sort of professional code or some sort of standard of care, but it's not with this eye towards actually like changing the profession in the way that you personally think is necessary.
I guess I don't read a lot of Rawls, so I don't know that I want to. I bow to the wisdom of other people about the distinction that Rawls makes. I guess a lot of this comes down to how you define these things, right? And I would say that I would categorize conscientious. I'm comfortable with conscientious objection because my biggest knowledge of it is from the Mennonites.
Mm-hmm.
And because I respect their lived example of that, I'm comfortable with that language. But importantly, if you begin there, so part of what's interesting in your argument is that you begin with you clearly know a lot more of the history than I do. You do terrific archival work. But in your article in Internal Medicine, you really focus on the Vietnam era, right? And in this book, you really go back to World War II more and history before that. And part of what's interesting is depending on when you begin with those, they feel very different. Conscience in the Vietnam War feels very different than conscience in World War II, right? And being against the Vietnam War is a very different thing socially than being against World War II or World War I. It just is. I mean, culturally in the United States, those were very different experiences. You had a lot of company if you were against the Vietnam War. And I think part of what I was struck by the difference between your book and your argument. And I guess I think that the lived example you come to something explains your answer. So for me, I'm comfortable with civil conscious objection, as including that you should see everybody, but that you should perform alternative service. So.
I mean, I appreciate the point that where you come from matters. And in my case, it comes from the military, as you said, but also military chaplains. And I think a lot about professional role responsibility through the lens of military chaplains, who are clergy, who are volunteers. Clergy are never conscripted, even when we have a draft. And one of the core responsibilities of a chaplain is to serve everyone in their unit or battalion or whatever group of people they're responsible for, regardless of their religious beliefs. So they're responsible for facilitating access to whatever the religious needs are, whether they're worship needs, baptism, study, marriages, funerals. And it doesn't matter the degree to which they are different from what the chaplain himself, and it was male chaplains until 1973, believes. And so that meant that was profoundly uncomfortable for many people. That was a choice they had to make about entering the chaplaincy, was would they serve people of other faiths? For many of them, this was incredibly meaningful service that changed their lives. But for Catholic priests prior to Vatican II and a lot of the work of like ecumenism in the 1960s, that actually meant violating certain papal decrees about interfaith work. So that was a choice they had to make about how they balanced their own personal religious convictions and the duties prescribed by the military. And similarly today, a Wicca in the military gets, their free exercise rights means they get access to a Wicca service. So even someone, minister, rabbi, priest, Buddhist priest, Hindu, you still have to find a way to help the Wicca engage in their religious beliefs. And to me, that was an incredibly powerful thing to learn over studying the chaplaincy, was the real commitments chaplains took on as part of their voluntary entrance into the military, was serving people of multiple faiths, and in ways that were really challenging for them, and challenged their own creeds at time, but still was the central commitment. And so I think that, really does describe in many ways coming at this from just very different starting points.
So when I read your book, I read that you're very aware of the ways in which the state shapes religious faith, and you're very attentive to pluralism and of wanting the state to allow pluralistic practice. And then the article in English for Medicine does not allow pluralistic practice. It discourages pluralistic practice on contested issues, and that's what I didn't understand, is how you've written a very thoughtful book about that, and the reality, of course, with our books is that people don't read our books. They read the short essays we write in prominent journals. That's the reality. That's not you. That's just all of us. People have short attention spans. And so in this debate about conscience, you're articulating that the profession needs to decide. But you don't take, one of the questions you don't answer in the essay, right, is which professional society? So within each profession, there's different competing groups, right? And I guess I would ask you, as somebody who's a member of a guild, what guilds are you members of?
American Historical Association, American Academy of Religion.
Right, so what if AAR takes an opinion that you don't agree with, right? What if you take a job at a university as a young scholar, and they ask you to teach certain things that you don't agree with? You would like the ability to resist that, right? You might take a job at a Catholic school that wants you to teach not to discuss abortion. I don't know.
Catholic University's not going to hire me at this point.
But, I'm just saying, like, you can imagine doing that and wanting to still have the ability to exercise what you believe is your conscience.
So this is a really interesting question to me. So if you believe in pluralism, and I believe that you do, I believe that you do.
I took the pluralism side. You took the anti-pluralism
But
side.
here's the thing. In this realm, the force of, or the constraints on pluralism are actually on the side of religious institutions. A Catholic hospital does not have to permit anyone in their space to do something that violates Catholic doctrine. And that's up to 20% of the US healthcare system, up to 40% in some areas.
Sure.
So there are any number of, there's a book by Laurie Friedman on willing providers and unwilling institutions, right? They're facing that they actually can't live out their professional commitments as set by their professional group in the institutions in which they practice.
So you say that because somebody freely chose a profession, they have to live with the rules of the profession. But you believe that when somebody freely chooses to work for a Catholic hospital, they don't have to live with that? I mean, talk about something. I mean, like, you know that going in. If you're an OB-GYN and you sign up at a Catholic hospital, I mean, come on. Like, at this point, you've got to know.
That's not totally true. Survey data suggests that is. I mean, you don't have to believe it. I was surprised too.
But a physician, caveat emptor, right? Like, I mean, so my argument to you is that an initial choice is not an assent to every act. But if you finish residency and you choose where to work.
So let me interrupt and ask one sort of final question that I think will open up the discussion nicely. So this is a Compass program, and it's an event in an ongoing series about religion in public life. And there is this interesting parallel discussion about freedom of conscience and also freedom of religious liberty. And so I think it's really noteworthy that, the U.S. Department of Health and Human Services Office of Civil Rights, the new division is called Conscience and Religious Freedom Division, right? And on the website, they talk about that when in the announcement of the division, it says The Conscience and Religious Freedom Division has been established to restore federal enforcement of our nation's laws that protect the fundamental and unalienable rights of conscience and religious freedom, right? And so I am not a historian, but from my, it's not in the First Amendment, right? And there is a very interesting history about how to protect freedom of conscience as opposed to how to protect freedom of religion in the United States, and it's very contested. And so, I mean, Madison wanted to put freedom of conscience or equal protection of conscience in the Constitution, and that was voted out, right? So there is this sort of interesting thing where it's like, just to open up and think about, is religion special, right? And if it's special, did HHS get it wrong by sort of protecting freedom of conscience alongside religious liberty? Or is there something, or did they get it right? And there's something actually really important about thinking about all these sort of conscience laws as something greater than just one's religious values and thinking more about one's moral values more generally.
I don't know that I want to die on that hill. I guess I would just say I do think that the freedom of assembly is a fundamental freedom, but fundamentally my argument is not American argument. Right? My argument, part of what's issues with the Mennonites is that they're a transnational community, and that they come with those commitments in respect of the nation state. I don't have much at stake with the constitutional argument. I haven't read. I've been meaning to read the HHS because I figured it would come up today. I've been busy. I haven't had a chance to read it. Fundamentally, I'm going to say there are communities that exist before and separate from those of the HHS and professional societies. So that's my interest.
I think the division uses the language of conscience for a very particular reason, which is that it opens it up to non-religious moral convictions. It's interesting though, because the case law on that is from these draft law cases and makes this, I think this is a really incredibly difficult distinction to make, but the justices were trying to make a distinction between what they understood as moral convictions and what they thought of as political, sociological, or philosophical ideas. Now, if any of you can tell me where to draw that line, more power to you, because I don't know exactly where that line is. But I do think that's why they're connecting the two. The conscience broadens it to non-religious viewpoints. I do think it mistakes religious freedom for a very specific kind of religious freedom that is tied to only certain views, only to refusal, not to conscientious provision of care. And I think there's a long and twisted history of the use of religious freedom both as an idea and a practice in this country. I know Tisa Wenger was here a few weeks ago, and she has a recent book on the idea of religious freedom and the ways in which it's a successful rhetoric for some groups and a really impossible rhetoric for others. So I think it's one of those things that sounds really broad, but actually disguises a lot of specificity.
So why don't we open it up for discussion? Does anyone have any questions?
Microphone or come on,
I'm going to
question?
go first while I sound check. Okay. So I have kind of a two-part question proposal thing. So I'm among those concerned about the loyalty or exit model. First of all, because I think looking at all the different possible issues is really difficult. So maybe just pick one of the ones you initially brought up about contraception, or whether contraception counts as abortion or whatever. So there's a fairly substantial amount of our society that does think that anything which terminates a post-conception entity counts as something close to murder. And so I worry that the loyalty or exit kind of model implies that roughly 50% of the population can't be represented in women's care or reproductive kind of care. And just to make it slightly personal, so I'm not a woman, but I've been I'm married for 22 years now, and I have 7 children and 1 miscarriage. And I can tell you, in that miscarriage experience, there was something pretty traumatizing about the fact that the doctor who was providing care in that case clearly thought that what we lost that day didn't really matter. And I would much rather have had a different physician in the room. It was pretty awful, actually. And so this brings me to my little mini proposal. How much of this could we fix with better labeling? Like, what if right there on the white garment, there was just like a little panel that said, like, here are some controversial things I believe, or here's what I believe about the controversial stuff.
She wrote about the pins they have to wear, right? She has a nice little bit about the
Or for heaven's sake,
wear, right?
if there are really doctors who don't know that OBs and or OBGYNs in Catholic hospitals aren't going to be allowed to do certain things, like, why isn't it just on the sign? You know, like Saint whatever's, here's the things we won't do, right? Would that kind of thing help?
Maybe. I think that's actually a question of how you communicate, right? And I think that for the most part, that kind of labeling is fairly ineffective. I think all the time people go around systems of whatever kind without labeling. I mean, most Catholic hospitals will tell you on their website that they follow the EOD, but I don't think most people read them.
It's not most, I just did a systematic review of the
Okay, fair enough. I have
659
not
hospitals in the
yeah.
Catholic hospitals.
On their websites, they don't list that they post the EODs?
That's correct.
Okay, so I guess I would say, to the extent that I hold out hope for our society, and that's not what I'm invested in, but I would like it to work, I think we have to talk to each other. I think we have to have some dialogue and some pluralism. And I do think it is entirely fair for, I don't know if I would wear a badge on my white coat. I don't wear a white coat anymore for various reasons. But I guess I would say, you should be totally honest with a patient. Like, the patient deserves total honesty. If you're never going to do something, I don't know why you shouldn't know that, right? So if a patient comes to me and wants, I get, this would be less contested, but medical marijuana. My hospital doesn't allow me to do a recommendation in Colorado. But I'll be totally candid with somebody about something. I think patients deserve my honesty. If I am not going to provide certain things, Colorado provides medical laws for medically and I'll tell a patient that I will not participate. But I'll be happy to help them in other ways. That doesn't mean I'm going to abandon you as a patient. I think those are two separate things. I think absolute honesty is something you owe to your fellow person, certainly as a physician.
So disclosure is really an interesting question because there's both empirical data and then there's, what it may or may not do. So there are a lot of people that end up in hospitals or with physicians in the context of OBGYN who don't realize, for example, that tubal ligations are a really common one that are requested fairly late and then can't happen. There are other circumstances related to miscarriage management where miscarriages end up taking, because of either hospital policy or physician convictions, no one will do anything even though the end point is known. And that is also traumatic. So I think it goes both ways in terms of what people want to know. A recent study came out that said, 30%, and again, these are large surveys, but not every person in the entire country. 30% of people said they didn't find it important or very important to know about someone's religious convictions or hospital policy or hospital identity, but over 80% thought it was important or very important if it affected care or restrictions. So it's an interesting distinction that in the abstract, people are kind of like, whatever, I don't know if it matters if my knee surgeon, or anything else, but that when they felt it affected care, they did want to know. But of course, what people read or pay attention to is hard. It's not always obvious.
They want to know an emergency versus a non-emergency.
Right.
It gets complicated.
It is, I think, really quite complicated. So I think there is something really appealing about turning to communication and disclosure as the solution. I'm not sure, though, that it actually covers the sort of scenarios where the clashes occur, and sometimes they occur, I hesitate to say, innocently, but, a recent case with a transgender man who had scheduled a hysterectomy with the OBGYN who was comfortable performing it, and then, you know, a nurse intervened and said no. So part of it is also some of these have complex teams where someone else who's not the person supposedly in charge can stop something from happening. And sort of what you do in that case, well, you need the nurse for the operation to proceed. What happens then? And for me, those are the really tough cases, because it's not clear to me that communication can fix that particular challenge, though it would be really nice if it could.
If you have questions, raise your hands so we see how many people have their questions. Okay. I have the microphone, so. I get the power.
So I wanted to try and think about maybe like a distinction that seems to be maybe getting a little conflated in the conversation. So you might think there's a difference between cases in which there's a dispute about what the kind of proper professional role is. So for example, like what exactly are the commitments of being a doctor, and what does being a doctor involve? And we could have different kinds of interpretations of what that amounts to. So if you thought, for example, that abortion was a form of murder, you would think, well, the professional commitment of being a doctor to do no harm rules out that kind of practice, where somebody might think, no, it isn't a case of murder, so it doesn't rule that out. That would be different from a case in which you have an individual who accepted certain kinds of professional commitments as legitimate to the professional role, but it conflicted with other kinds of personal commitments they had, moral or religious commitments. And that, I take it, seems to be like, those are often run together in the kind of conscientious objection cases. And so I was wondering if you two would be willing to speak a little bit on how that distinction might shed light on the kinds of judgments we want to make about when refusal would be permissible versus impermissible.
Can you give an example of what you're thinking about in the second case?
So it's tricky. So you could think all of the examples coming to mind, of course, are the professional role disputes. You could, so I'm envisioning maybe somebody who thinks maybe like the science is out with respect to how contraceptive, like the science is out with respect to the status of a fertilized embryo, and so they aren't sure whether contraceptives are a case of murder, so they think it could be compatible with their professional role to be willing to write a prescription, but they're personally very uncomfortable with it, maybe given they don't want to take certain kinds of moral risks, right? They're conservative with respect to their moral risk taking, right? So they would rather not prescribe. So that might be a case in which they're willing to accept that maybe professionally speaking it's acceptable, but personally it violates certain kinds of moral commitments they have.
Yeah, or psychological commitments, right? Risk-taking is a sort of stable psychological over time. And there are some procedures you might have to do because you're
Can't hear you.
more risk-averse. You want to answer the question on that?
Well, I'm just trying to sort of play out the two versions in my head, so maybe a little bit.
Yeah, I'm not sure that I know the answer
Yeah.
either to your question. I guess I would say one weakness that I see in my argument is the Mennonites are a minority religious group that, especially at that time, were very formed in a crucible, right? They had gone through World War I. They lived largely isolated. They lived sort of separate from American society. I'm not sure that the Mennonites could do the same thing today, to be honest with you. And it's not clear to me that that kind of communally formed conscience exists. And I think in quite the same way, and I wonder if people make decisions for multiple reasons, and some of that is just how comfortable you feel taking risk, which I think can be a morally neutral term. I'm not a big risk taker, but by which I mean, like, when I ski in Colorado, I'm not a very aggressive skier. I don't think of that as a particularly moral commitment. It's just psychologically, I'm a pretty safe guy. That's how you become a psychiatrist, right? And not a trauma surgeon. So I can imagine that some practitioners make prudential decisions all the time about which procedure to perform, in which situation. Is it a tubal ligation? Am I going to use forceps? All of these things there's not clear rules necessary in the, I wonder if I'm going to get kicked out or something. Okay, so I guess that all of those things are involved. We tend to isolate conscience, but there's a lot of different things that go into decision making: communal conscience, personal conscience, psychological constructs, the influence of society. But again, I don't know that I have a great answer to your question. So I'm not sure what the difference is per se.
So raise your, oh sorry, raise your hand again if you have a question. Let's see. So there's, I believe, like 3 or 4 people, and there's 15 minutes. So let's try and ask questions and answer questions in like a fun room. Yeah. Okay.
Who's next?
I'm just kind of concerned about all the times that people don't get to choose their physician.
I'm sorry.
And there are a lot of times that people don't get to choose their physician. You can talk to your OB about what he would and won't do. I can talk to my doctor about, end-of-life care. From an emergency room perspective, I've got real problems if someone stops CPR on a woman when her lesbian partner walks in. That's a very different situation. She didn't choose this physician. And the physician objects to this procedure. I've got problems with his right to say, I don't treat this kind of patient.
I do too. I think part of what I objected to in the New England Journal of Medicine essay is that I thought it collapsed those differences. I have no time for somebody who refuses to see a patient. And I can't, I would happily report that person to the medical board if they refuse CPR because somebody knows.
But a case where that's happened where there's no consequence is like a pediatrician who refused to treat the child of a lesbian couple, and because of state conscience laws, that was okay.
Sure. I don't know that case, but I'm not defending it. That's not my argument. I can't imagine refusing to care for somebody because they're lesbian. It's never occurred to me as something to do. And importantly, the example, part of why I started with the Mennonite example is that they did not open hospitals that were just for Mennonites, right? They chose not to do state psychiatric hospitals because they didn't believe that the state psychiatric hospitals were fully committed to non-coercive care. And they needed to do other kinds of care. But Mennonite facilities see all patients. I think those are two very different things, between seeing patients and not being able to provide all of the possible procedures available. All the time I have patients who come to me and ask by name for specific medications that I refuse to provide them. And I would be a liar if I thought that various kinds of unconscious bias weren't working in that situation. I believe unconscious bias works in all life. Implicit bias, it's out there. So it would be ridiculous if I said to you it wasn't for that. But fundamentally, why am I giving somebody Xanax in the psych ER? Is because I don't believe it's the right thing to do, and I try to do that consistently. But I see all patients. I staff the jail sometimes. I see people who've done all sorts of things. That's not my argument.
Great, very nice presentations. Thank you, Ryan. So the concern I have is making, bad cases make bad law, and it also makes bad theory. And I think, that's my criticism of the New England Journal paper. I think it's bad theory because it's bad cases. In medical practice, as an administrator for over a decade, we deal with these all the time. And we have nurses and staff and physicians that come from all different walks of life, and they have different views of health. I really like Laura Spalgin's book that just makes these distinctive, different views on health. We work them out. Only rarely does it come to someone having to leave the facility. It should never mean a patient's not provided care, though they may not get the exact procedure they want. The elephant in the room here is that I don't think anyone that's arguing for the destruction of conscientious refusal is really concerned about Mennonites. I think they're concerned about abortion, and they're concerned about physician-aided dying or euthanasia. They're concerned about LGBTQ rights and gender reassignment. So if we focus on those, I think we could have, something that would really get at this kind of culture war discussion. But even then, I think it's easier to go through the practicality of what we actually do in the health system, which is not what we're speaking past in this. So with gender reassignment, the quandary that you have is, well, there are a lot of gender reassignment comprehensive centers. If I had a surgeon on our medical staff that said, I don't do that, we would refer a patient to a comprehensive gender reassignment center, which there are many in the country. There is a question of conveyance, which was kind of one of the key issues in abortion. How far is it reasonable for someone to have to go to get a certain legally available procedure? That's a real question, but generally it's taken care of right. The question of, I like the conscientious refusal in military question. I wonder why you have, Ronit, it seems like you're opposed.
Sorry, can you speak into that? I can't.
Sorry, that's better.
I'm saying this right, but it's hard to hear you. It's not really the problem.
So I wonder why you're opposed to the merchant marines. You know, I would view an alternative type of medicine that is available as akin to allowing the conscientious refusers to be in the merchant marines instead. The problem with disclosure that I see is that it usually only asks one side for disclosure. It usually only asks the people of faith that are refusing to disclose, but the atheist who's wanting to proselytize New Age Buddhism doesn't have to disclose that. So disclosure is kind of a tricky double-edged sword. The final thing I'll say is if you observe the main three questions on conscientious refusal, so abortion, gender reassignment, contraception, and euthanasia, the standard medical practice in those have changed radically in the last 50 years. So to claim a standard medical practice, if you poll physicians, you're going to get a different standard than if you poll kind of cosmopolitan liberal academics. They'll say that ought to be. So it really incomprehensible to me that people will say, no, your profession must do what we think is the good, right, valuable, and healthy, because if you're not willing to do everything legal, then you have to be exited from your profession. But don't touch mine. And it just seems hypocritical. So just a few comments.
I guess the question that I think rises out of the points you make is, why is it that in these contested realms of care that are, some of which are contested within the profession, within subspecialties, some aren't, but why, when it comes to what is legally required, is it such a different standard than we hold any other realm of healthcare to in the sense of malpractice, right? Malpractice suits in other realms of healthcare, the classic move a lawyer is going to make is, well, what's the standard of care? Like, that's how you determine if there's even a case. But you can't even make that case in these realms, because even if there is a standard of care, let's take ectopic pregnancy, for example, a space where, you know, if you don't tell someone that methotrexate is an option that will preserve their future fertility because it violates your religious convictions, and instead the only option is to remove the fallopian tube that will deny them future fertility, there's no malpractice suit to be made. But if you didn't tell someone there was, a knee surgery that could fix their knee.
There is claim for a malpractice suit.
Sorry?
There is claim for a malpractice suit in that case.
Well, the conscience laws in most states say there isn't.
Malpractice is what a reasonable, prudent, compassionate physician would do in a similar circumstance. You could find someone to take that case.
When they have attempted to bring those cases, the courts have thrown them out under the grounds that they fall under the conscience laws.
For ectopic.
I can't, I'm sorry, I just can't.
For ectopic.
For ectopic, yes.
So, but I think fundamentally that question about how professions change over time, I think that's one of the questions I put to you with the question of the American Psychiatric Association considering homosexuality as a mental illness, sexual deviance as a disorder. And it's a problem on a number of levels to root this argument in what a professional society says because practices change, and because I still haven't heard you say, why is it that when we assent to something at the beginning, we're assenting to everything that profession does, right? That seems like a weird argument to make, and I'm struggling to understand. Help me.
So, to me, you're making...
When I assent to joint psychiatry as a medical student, I was never told all of these things, that I would be expected to participate in takedowns, restraints, was never something I was told. And then I'm expected to the first day, right? And so you say it's a freely chosen profession, but at that point, I can't go to the match for another year, right? If I've left psychiatry after one day, it's very hard for me to match, right? I can't leave the professional society. I mean, I was struggling with that, just based on the actual experience of living inside a profession.
Well, okay. So a few things. First of all, I think it's interesting that you raised the distinction that it would be different for someone to not recognize the sort of full swath of expectations for a given specialty, and that is different grounds than someone who is in a hospital setting where the hospital is telling them they can't do things. Is that different? I can't tell from what you said earlier. Is that different?
Yeah.
Should they be knowledgeable? Why in one but not the other?
So the reason why I focused on professional, because that was your argument, right? Is that you said that the professional society is what matters. And there's a difference between a professional society and a hospital setting. There are multiple hospitals. I recognize that in some places in the country, one hospital system may be dominant over another, but there's one American Psychiatric Association, right? Like, I can't, if I move to California or Montana or Iowa or deeper in Mississippi, it's still the same American Psychiatric Association. And in the 60s, in their diagnostic manual, being homosexual is a mental illness, right? Like, that's...
Right, so that gets to my point that it has to be patient-requested care, right? This isn't about, like, because these objections and the way that, again, the law frames it is a refusal to provide certain care or certain intervention.
So
it has to be patient-requested.
If I joined some small psychiatric association that believes in conversion therapy, which I don't believe in, and a patient requests it, you would want me to do it? And if I wanted to do it, I suspect you wouldn't.
But again, then what's setting the standard? So what, because you're saying this is like the renegade group over here, right? The renegade professional group.
No, I don't think it is at all. I'm just saying, that I don't think there's anything in your argument that adjudicates which professional society matters. You just said profession, but you don't at all clarify which profession matters. I mean, there are so many professional societies, they all want my CV money. I mean,
Sure they do.
Right, like, I mean, your argument doesn't
Let me
Can I
yeah,
stop
okay.
for a second? I think there's two more questions.
Yeah, sorry.
And so let's ask those questions and then we can have
Yeah, sorry.
ending comments.
One of the questions I had was kind of on outcomes. Because the function, and I'll go back and use the Mennonite example differently, but if the purpose of having the Mennonites in the mental hospital was to provide patient care, they obviously did that. And that was a wonderful function that they accomplished. Although it may not have been the standard of care at the time, and we all recognize that care has evolved and options in all kinds of medical professions have changed and expanded over the years. But then we get to the question of the nurse, if I understand, who was in the women's clinic, who refused to perform certain tasks, give certain medications, or give information regarding things that are part of the standard of care. The outcome then is not satisfactory. And does the outcome not sort of explain why conscience laws would not be acceptable?
So let me bite your tongue, think about it, and then we're going to have Dr. Howard ask the final question.
There's another Dr. Howard?
Yeah.
How many doctors? What is the deal? In Ohio State, does everybody have to be called Howard?
No relation, but it is a strong.
How about a little diversity, Ohio State?
I was thinking about how the argument for dialogue and pluralism rests, I think, on abundance. Like, you have to have a lot of available doctors, with like some of them declining to treat patients by some recommended parts of their professions. I know you're saying it's not okay to refuse to see patients.
Not okay.
I wonder what you make of like a harm-inflicting scenario, not of someone refusing to see a patient who's a lesbian, but someone who wants to treat
a lesbian with depression with conversion therapy. And is that scenario like the cost we pay to live in a pluralistic society? And if there are no other available doctors, yeah, what about the harm? Because I was thinking, I like all your examples. I love the Mennonites who don't want to use violence. What about an example that's harmful?
Yeah, so I think it depends on which one it is. Let me answer these in turn. So the question is would outcomes matter? And I would say I'm not making an outcome-based argument, I'm making a process-based argument. I believe that even if the Mennonites didn't have good outcomes, it was still the right thing not to hit people with mental illness, okay? Right? Even if they didn't have good outcomes. So I'm not making an outcome-based argument. I believe that society grants physicians extraordinary rights to do things that are otherwise invasive in the system. I said this in English. And I believe that they have responsibility, the fiduciary responsibility to expect and time from us. But I believe that fundamentally that comes out of a patient's vulnerability, right? And so I would say that the question isn't about outcomes, it's about how do you respond to a vulnerable person. And I will insist to you that the largest selective or conscientious refusal over and over again in this society is for the poor and the vulnerable. And it is at large academic medical centers like this, okay? So I am a proud citizen of the state of Colorado. The University of Colorado is a 1,200 bed hospital. They have an additional 14 campuses across the state of Colorado. How many psychiatric beds do they have? 0, right? That is the conscientious objection selective refusal that happens every day. So these examples are hypotheticals. The real example is the refusal of the poor every day. So in my argument, what matters is the question of how you respond to a vulnerable person, right? And the problem with responding to a lesbian woman with conversion therapy depends entirely upon how you respond to her vulnerability. Because in her argument, right, you could have a professional society that endorses conversion therapy. You could also have a patient-centered account, a consumer patient-centered account of medicine where you give the patients what they want. And if somebody says, I've tried this, but I no longer want to be a lesbian, that's not my argument. But you can imagine an argument that fits with it. My argument is fundamentally that we are all vulnerable people, and sometimes in different ways and more or less things. And that your job as a physician, you are allowed by society to respond to that vulnerability. And the failures you make as a physician and another practitioner is the extent to which you do not respond to it. But I will hold open the possibility that there might be a time when that might be the right response, even though it's not something I would ever want to do. But I would never turn away a person who's vulnerable, right? I have a patient on the floor I saw this past week who had chosen to, he had devil horn tattoos on his face. He had swastikas on his cheeks. He had Sig Heil on here. He literally had SS insignia all over his face. I find that abhorrent. I'm out on Nazism, right? Like, it's a hard no, a hard pass on that. But I'm his doctor. He was assigned to me. My name's Abraham Nussbaum, right? Like, and he's gonna throw some stuff at me. Such is life. But if he says, but I did say to him, I'll confess to you, he said, I'm having trouble out in the world because people look at me funny. And I did say, I said, have you thought about having the tattoos removed? Just as a polite, idea, like maybe. He's like, you think they're upsetting people? I said, I think they are. I think that might be part of it. And we had that conversation. But I don't enjoy his tattoos. I think they're horrible. But I'm going to be his doctor. I'll be back there on Thursday, right? And I think you have to respond to people's vulnerability. That's what makes me a physician.
So I appreciate the stance that treating patients and thinking of them in their vulnerabilities, and that's an important space to be working across and to develop a relationship that honors that and respects that. But the question then that I have is, how without some sense of professional standards, whether you agree with all of them or not, can a patient figure out what to expect? Because from my perspective, a patient should be able to enter a clinic and expect professional treatment, not someone's personal views. And the question then is, where do you go? If it's not the professional societies, what can a patient use to assess what they could expect when they're seeking care? What are the range of options? What information should be presented to them? What did they miss? What can they think through? And it seems to me if there's an a priori objection based on religion or a moral conviction that is not shared across the patient-provider relationship, then you can't actually have that dialogue. Because there's no space for dialogue if there's an a priori resistance. And I think that the point about poor and underserved patients is incredibly important, but those aren't objections, those aren't rejections of service that are being at least articulated on the basis of conscience. No one is invoking conscience clauses to not treat poor patients. Now maybe that's what's behind it all, but that's not the language being used or the laws being asserted to protect that action.
I think that's true. I say that as an example of, if you think professional societies are patient, you're arguing that they are what preserve patients' rights or patients' needs. And I would just say, that's my argument why I make that argument. I do not believe that they're making that argument on a conscious basis. I'm clear. What I promise every patient is that I will be professional. I will see them no matter what. I will recognize their vulnerabilities. I will try to increase their agency. But that is the a priori commitment I have to them, is to see them no matter who they are, no matter where they are, no matter how sick they are, no matter whatever they've done in life, right? And I see some remarkable people. I love my patients, but I don't make an a priori commitment to procedures. I make an a priori commitment to people. And that's my commitment.
And I think we have to end it there. And thank you everyone for coming. Thank you so much, Dr. Nussbaum and Dr. Stahl, for
Hello, Howard!
an exciting conversation.